Thank you, Professor Lee, for your kind introduction. So I will discuss, I will share that the sphere from dosimetry to clinical outcome. Actually, my content is quite relaxed, it's easy. So just use a few cases to go through the expert recommendation. So this is my outlines. So like I said before, right now in Taiwan, the Y90 can be integrated to multidisciplinary the treatment. However, still in the very early stage, not like the Western guidelines. So we still cannot recommend that using the Y90 to small, for example, less than 3 centimeter tumors, because most of the hepatologists they think that ablation or surgery is good enough. So the dosimetry start from this schema. So single compartment models assume that it is a uniform distribution of the Y90 particles in the perfused volume. But all we know that is not true. So for the multi-compartment models, it's more reflect the real sphere distribution, especially the heterogeneity of the piece distribution. So it's kind of evolution toward the dose mapping from the BSMN model. Right now, I think most of the doctors never use that. But for the single compound model, actually, if you perfuse only a very small volume, I think it's still quite useful to practice. But however, multi-compartment model, nowadays we use a multi-compartment model, or in some institute use the voxel-based the model to evaluate the pre or post Y90 dose distributions. So for regarding the sphere, this kind of a journey of the dose escalation. Firstly, start with the 190 is the first recognized ablative dose based on single compartment dosimetry. We can say that is the start of the radiation segmentotomy. Then dosisphere 01 proved that 205 is based on multi-compartment calculation is a personalized dosimetry and can significantly improve the objective response. And also it's including the overall survival. And then legacy study shows that is a new threshold dose, the 100% complete pathological necrosis (CPN). So if you can achieve that based on the calculation, I mean, is the voxel-based calculation, actually you can achieve a complete response. So voxel-based dosimetry in radiation segmental HCC, actually there are several studies. In this study, you can see that if you can give the D99, which means 99% of the tumor covered by over 500 gray dose, you can achieve the complete tumor necrosis without the grade 3 toxicity within 16 days. So we use the demo version of the simplicity in our institute to calculate our treatment outcomes. We enrolled 34 patients underwent GLASS Y90, and finally 30 patients enrolled. Among them, 23 are HCC cases. We try to compare pre-procedure MA SPECT CT and the post Y90 PET MR. So actually, for the responder group, we can see that the dose, the tumor absorbed dose is greater than the stable disease or PD group. And post Y90 dose actually is higher than the pre-MAA dose. And this is our data. So let's use a few cases to go through the recommendation of the multidisciplinary work group. Professor King is one of the authors. So this is kind of the guideline can help to the starter or doctors to follow the treatment in different scenarios. So the dose calculation is recommended. The multi-compartment dosimetry is recommended. So scenario one is radiation segmentotomy. So 1400 gray have been mentioned many times in this session. So they recommend week 1 or early week we dose to do that. So this is of 5.7 HCC in segment 7, quite good liver function, equals 0, child 8. So in this case, we think that we can do radiation segmentectomy in different different vessels. So the tumor dose, absorbed dose, this is the based on MAA calculate. So it's more than 400 gray. So 6 months later, it's sustained complete response in these patients. So the second scenario is radiation lobectomy. It's kind of the curative intent if you want the patient to go to the liver transplant or receive the resections. So the patient selection should be a good liver function patient, child PUA, with if there is an inadequate future liver remnant, and then you can do that to make the contralateral lobe hypertrophy. The recommended dose for tumor based on the multi-compartment model is more than 205 gray. In the same time, you should keep the normal liver dose less than 120. If you use a single compartment model, 140 to 150 gray lobe absorbed dose is the limit. So I think it's not really the lobectomy because the tumor occupies all the right lobe. So this is a big tumor. So there is a 70 centimeter HCC right lobe with AFP level more than 600. So the lung shunt fraction is not so high, it's 8.2. However, due to the big tumor size, we cannot give a very, very high dose to the tumor. So in this case, we administer different week and dose vial to the tumors. And 3 months later, you can see that the left lobe hypertrophy and the right lobe is partial response. So then the patient, due to the enough liver remnant, the patient underwent resection and only 5.5% of the residual viable tumor. The scenario 3 is the tumor with the vascular invasion. Is a multifocal unilobar HCC. I think the intent in this kind of patient is a palliation to delay the disease progression rather than a curative intent. So actually, you don't need to give very high dose. So the dose calculation, you can use the single compartment or multi-compartment models. So for the single compartment model, similarly, is 120 to 150 gray to all the perfused lobe. For the multi-compartment model, if you can target more than 205 gray to the tumors. So this is a multiple nodule in the unilobar. So the FP level is quite high. So in this case, you can see that there are different feeding arteries to different mass. So we select each by each, and we calculate the volume and the lung shunt fraction. The lung shunt fraction actually is borderline, it's 11. So we think for a safety issue, we decide to perfuse 120 gray to the perfused lobe. It's the average. So we use a 3 week to 15 GBQ vial to the tumor. And after the treatment, you can see that there is still some heterogeneous distribution of the tumor in the non-dependent part. So actually, there's a viable tumor, and for the dependent part, you can see the calcification and the tumor shrinkage, which means there's very good or near complete response. So for the large tumor, maybe to prevent the heterogeneous distribution. So in this case, we think that we may do more selective better. So in scenario 4 is the bilobar HCC without microvascular invasion. So bilobar disease always we need start the first is to think about the palliation rather than curative. So because it's a bilobar, so you don't need to target, and also the palliative intent, you don't need to use very high dose to the tumor, or you need to limit your dose to the normal liver parenchyma, less than among 40 to 70 gram absorbed dose to entire normal liver. So this is another case. Is the tumor in the both lobe, because in this case actually you can do 2 segmentectomy, so it's not so diffuse. So in this case, we selected the different the feeding arteries in the left and the right. So this is the lung shunt, is 70.4, sorry, 70.5. So in the lateral segment tumor, we can give, because we can do the relative high dose. So the tumor absorbed dose more than 400 gray. So we use week 1, 5 GBQ. For the right, it's relatively small. So week 2, 3 GBQ is enough. So this is 9 months after Y90, near complete response. So the last is scenario 5, HCC with microvascular vascular invasion or portal vein thrombosis. The treatment intent is palliation. So the dose calculation is based on how much the future liver remnant, the liver function can be preserved. So the function, future liver remnant is the key considerations. So this is the portal vein thrombosis infiltrative tumor. So in this case, you can see that there is a significant AP shunt. However, the shunt is to the epilateral side of the tumor, not contralateral. So if the right lobe volume, if the left lobe volume is enough, we don't need to worry about that too much. So based on the MAA, we do the calculation. So we give the we use separate the dose to the different feeding artery. So the week 2, 3 GBQ and the week 1 GBQ to the different part. So okay. So this is the tumor is the different part is more than 190 gray. So you can see that after the treatment, actually the follow-up, because the patient had got the intrahepatic metastasis in the segment 6, so we try to do the embolization. But during the procedure, we cannot find any tumor stains in the prior treated target. So this is, I think, maybe the last case. So it's the bilobar diffuse. No, not diffuse. Infiltrative tumor into bilateral portal vein VP3 or even VP4 invasions. So you can find Schlechten sign beautifully in both sides. So in this case, we use the 4 GBQ to the right and the 5 GBQ to the left, such as like this. So this is a treatment outcome. So 6 months follow-up MRI showed good response with reduction of the restricted diffusion signals. And however, the patient expired due to infection complicated with the hepatorenal syndrome after 7 months. So this is my last slide. Dose calculation is one of the most important steps of the TAIR. So the tumor episodes significantly correlate with the pathological response, like the many experts in this session have mentioned that. So for glass Y90, tumor episode dose nowadays is more, if you want to achieve complete pathological necrosis and the durable response, 400 gray or greater is recommended if you can do it safely, like Professor Choi said. So modern software allowed you to tune the treatment strategy and confirm the real dose distribution. Thank you.